All right, thank you, Nellie, and good morning, everyone. This is a joint meeting with Senate Health and Welfare and House Healthcare. It is Cinco de Mayo. Welcome to May 5th, and we have a lot of testimony this morning on our issues around telehealth and telephonic communication for healthcare. So I've asked Jen Carby to tee this off so that tee it up, not tee it off, tee it up, to put us in the right place so we can listen to testimony. So we did a lot of work in S 742 Act 91, and Jen, you're going to kind of bring us back to where we need to be. So thanks for being here.
Sure. Jennifer Carby, Legislative Counsel for the record. So yes, just to give you a few reminders to kind of set the stage. So the first is we are talking today about telehealth and telephone. Telehealth is the kind of umbrella term that we generally use to incorporate telemedicine, which is the live synchronous transmission, audio and video between a patient and a provider. It also includes store and forward, the asynchronous, not at the same time, transmission of some kind of medical information from either the patient or a provider to another provider who is not present where the patient is for review, not in real time. And telehealth also typically includes some form of remote telemonitoring in which medical information may be transmitted from a patient's home to a provider at another location who is tracking some medical information like blood pressure or pulse, things like that, to keep track of and monitor the patient's status. So that's telehealth. Separate from that, in most people's vernacular in this area, is telephone, which is communicating, a provider and a patient communicating over the telephone without any visual involved. And so we will be talking today both about telehealth, which you incorporated some ongoing language in Act 91 on, and telephone, which you allow DFR to adopt emergency rules regarding, and which they have done. So in Act 91, you made some changes to our existing laws on telehealth to do a few things. One of them is to add dental services into coverage for telehealth, both telemedicine and store and forward. And another is to expand and require reimbursement for store and forward. So under prior law, there was permissive language allowing the carriers, but not requiring them, to reimburse or provide coverage for two types of store and forward, for teleophthalmology and teledermatology. Under the language that you passed, you expanded that to be all types of services as long as they are medically necessary and clinically appropriate for delivery through store and forward. And you made the store and forward provisions effective on January 1st, 2021. So you required health insurers to cover or reimburse for services delivered by store and forward means beginning on January 1st, 2021. But then you also, in a different section of the bill, gave some direction and emergency rulemaking authority to the Department of Financial Regulation, DFR. And in that, in Section 8 of the Act, you stated an intent to increase Vermonters' access to medically necessary healthcare services during a COVID-19 declared state of emergency. And during this state of emergency, you said that the Department of Financial Regulation must consider adopting and shall have the authority to adopt emergency rules on a few things for the duration of the state of emergency. And one of those was that they had the authority to adopt emergency rules to expand patients' access to and providers' reimbursement for healthcare services, including preventive services, consultation services, and services to new patients, delivered remotely through telehealth, audio-only telephone, and brief telecommunication services. And DFR took that authority and adopted an emergency rule H22002E, coverage of healthcare services delivered through telehealth, telephone, or store and forward means. The rule is in effect for the duration of the state of emergency, which is what you gave them the authority to do. And it requires, where clinically appropriate, that health insurance plans provide coverage for all healthcare services delivered remotely through telehealth or audio-only telephone by a healthcare provider at a distant site to a patient at an originating site to the same extent they would be covered if they were provided through in-person consultation. There was some additional language, but I also wanted to talk about the timing of the store and forward. So the DFR emergency rule has two pieces on store and forward. One says that all health insurance plans shall provide coverage and reimbursement for store and forward HCPCS code, which is a particular medical code, G2010, and it says in the rule, remote evaluation of a recorded video or image. I think it's helpful to know a little bit more because the actual text of the HCPCS code 2010 says it's remote evaluation of recorded video and or images submitted by an established patient, and then it says e.g. store and forward, including interpretation with follow-up with the patient within 24 business hours, not originating from a related E&M service provided within the previous 7 days, nor leading to an E&M service or procedure within the next 24 hours or soonest available appointment. So basically something that took the place of another appointment, but this is specifically evaluating something submitted by an established patient. So that's the first piece of it, and there's no specific date given in the DFR rule on that piece, which I take to mean that it is subject to the claims retroactivity language, I think, that says all health insurance plans shall process and reimburse appropriate claims for telephone triage services and healthcare services delivered through telehealth or audio-only telephone retroactively to a date no later than March 13th, 2020. Then they also go on in the DFR rule to say that the provisions of Act 91 relating to coverage and reimbursement for healthcare services or dental services delivered by store and forward means shall take effect on May 1st, 2020, if there's a declared state of emergency in effect at that time, which there was. So I think the short version of all of this is that under the DFR rule, the store and forward language that you passed, instead of taking effect on January 1st, 2021, took effect on May 1st of this year and will last through the duration of the state of emergency. There also seems to have been a requirement to cover a particular type of store and forward, the HCPCS code 2010, the remote evaluation of a video or image sent by an established patient. That may have been in effect earlier than that. And the telephone coverage pieces will last and not, at least for telephone triage services, would last with no cost sharing through the end of the state of emergency, and other telephone coverage would also last through the end of the state of emergency. So you have store and forward, which in some form or another will at least last through the state of emergency and then take effect again in January of 2021. So there may be an interruption of coverage there if you don't do something to address that date, which I think is part of your purpose of discussing this today. The coverage for telephone services lasts only through the state of emergency, and then there's no requirement after the state of emergency for health insurance to cover services delivered over the telephone.
Thank you, Jen. That's a terrific summary, and I know that what might be helpful is I'll ask Nellie, we can ask Nellie and Demis to put a link to the DFR rules in case committee members haven't read those yet. I think Senator Cummings and I have both seen them. But unless you're looking at LCAR work, you don't always see the rules. So,
and I'll send the link right over.
All right, that's terrific. So, Owen, I see Sebastian Arduengo has sent them. as
Oh,
well.
okay.
Or,
Well, then I'll let Sebastian do it.
but they're
His rules.
sent to us here on our Zoom. I don't know if Nellie has them available. She can cut and paste, I guess. It's great. Thank you, Sebastian, for that. So Jen, thank you for the summary. I think we're going to go right ahead and listen to testimony from folks. And we're going to try and hold our questions until the very end of committee meeting, simply because there's so many people in line and we have so much to cover. I do have a question of clarification for you, and I don't know if you can answer it, or perhaps that'll come up as we go through our testimony. But when we say telephonic, today our telephones have FaceTime.
Right.
So with that, if it's a FaceTime on a telephone, is that telephone or is it telehealth?
So if there's a live audio video connection, which I think FaceTime would afford, I would consider that, although it's probably more up to DFR and to the carriers, but I would consider that to fit in the telemedicine side, although mainly only during this time when the federal government, when the U.S. Department of Health and Human Services is relaxing its enforcement of HIPAA requirements around a secure audio video connection. So during this time, I think you could use FaceTime as telemedicine. After this time, that would no longer work because it would not be HIPAA compliant.
Okay, thank you. And that's a good reminder about HIPAA for us as we're thinking about how and whether and what to extend. Okay, thank you.
Can I just,
Bill, do you have a question or comment?
just one quick comment. As I recall, the reason that we initially had the store and forward effective in January of 2021 was at the request of the carriers to give them the opportunity to implement changes. And so that was the rationale for a later implementation date initially from the legislation.
Okay.
Yes, I think that's right. And I think they have been able to stand that up in a shorter amount of time in response to the DFR rule. Right.
Thank you. Okay. So we'll move on, and Anissa James is here from DIVA, and also Anissa, Hillary Hill is here with you. Do you have a team presentation? I'll turn it over to you, and you too.
All
Nissa,
right,
welcome.
wonderful, thank you. For the record, Nissa James, Department of Vermont Health Access. Can I just confirm that everybody can hear me okay?
Yes.
Yes.
All right, wonderful, thank you. So I believe the DIVA team was asked to speak about the changes that we have implemented specific to the temporary coverage of services delivered by telephone during the emergency response, but I'll also touch on our existing coverage for those services delivered through telemedicine. I believe I do have my colleague Hillary Hill on Zoom as well. And so she is a healthcare administrator who works with our Medicaid policy unit. And I don't see her video on right now. She may be joining by just audio only.
I'm here.
But I will go ahead.
I can hear
Wonderful.
her.
Okay, great. Fantastic. So as you know, Vermont Medicaid implemented several changes intended to ensure access to care for Vermont Medicaid members immediately following the declaration of a state of emergency in the state of Vermont. And this was really looking at not only assuring access to care, but also enabling Vermont Medicaid participating providers to receive reimbursement for the services that they would furnish for their patients during the emergency. And that was in consideration of the guidance that was really focusing on maintaining physical distance in order to slow the transmission of the spread of COVID-19. And so we were looking for a way to be able to assure access to care and enable providers to be paid without requiring patients to travel to a healthcare facility in recognition of that guidance, but also without requiring the use of telemedicine. Because exactly as Jen Carby indicated, telemedicine really is that two-way, real-time audio and video interactive communication that we focused on, solidifying the definition and terminology around ahead of the emergency, actually. And what we recognized in the state of emergency is that many patients are either not comfortable with using that interactive communication that requires both audio and video/video, or they may not have access to the equipment that they need. And that could include smartphones, HIPAA compliant platforms, pre the waiver of that requirement, or even broadband or cellular service. And so it became really important to offer a way in which Medicaid members could receive services during the emergency, and that Vermont Medicaid could also provide temporary coverage and reimbursement for those services. And in the midst of developing that approach, we did continue to emphasize and encourage that Vermont Medicaid participating providers continue to use telemedicine for healthcare delivery whenever possible. And this is in part because Vermont Medicaid has a very generous coverage for telemedicine. And so we wanted to ensure that when medically necessary and clinically appropriate and able to be utilized, that telemedicine was still used for healthcare delivery even during the emergency. But in recognition that patients may not want to use it or may not be able to use it, we also developed an approach to provide new temporary coverage of services that would be delivered by telephone, and that's frequently referred to as audio-only services during the emergency response to COVID-19. And this was in part turning on coverage for the 3 G codes, which you've probably heard referred to as the triage codes. So this is one of the ones that Jen referenced in terms of the remote evaluation. That's the G2010. There's also the G2012, which is considered a virtual check-in. And so that's a virtual check-in between a provider and a patient using a brief communications technology device, of which a telephone could be one of those that would be used. And so those codes are specifically to determine whether an office visit or other service is needed. And so they're only billed if they don't result in a service needing to be delivered in the next 24 hours or result from a service that was delivered in the past 7 days. And so hence the terminology that's frequently used is the triage codes. I do want to note that the G2012, which is that virtual check-in, and the G2010, which is the remote evaluation, those are the codes that are specifically used by providers who are not located in a federally qualified health center or rural health clinic. For providers who are providing services through a federally qualified health center or rural health clinic, there's just one code, and that's the G0071. And we tried to make that really, really clear in the guidance that we released from providers. And out of all the questions that we did receive that we've compiled into a frequently asked questions document and continue to update, that actually was not one of the ones we received. So I think that was fairly clear in our provider communications. In addition to turning on temporary coverage and reimbursement for those 3 triage codes, which again were really intended to provide reimbursement so that providers who were doing those brief check-ins with their patients to determine whether an office visit or other service was needed. We also, through engagement prior to the emergency, which many of the members of the House Committee on Healthcare are likely well aware of, the side conversations that were happening in the hallways outside the committee room, we worked with various provider associations to look at how we could really meet the need to provide reimbursement at the same rate for medically necessary and clinically appropriate services that would be delivered by telephone were a state of emergency to be declared. And so that really looked at going beyond what we had previously provided coverage and reimbursement for. So there are E&M codes that Vermont Medicaid previously covered that were specifically indicated for delivery by telephone. And there are 3 different codes, and it's based on the amount of time that the service requires. However, those reimbursement rates were lower, and in terms of utilization, they were not frequently utilized by providers. So one of the requests of the provider community of Vermont Medicaid was to look at developing an approach that would allow providers to continue to bill Vermont Medicaid as they normally would when a service was delivered either in a face-to-face setting or through telemedicine, but be able to differentiate that it was in the state of emergency being delivered by audio only. And so as a result of that, we developed a process where we convened a multidisciplinary team to begin to assess services for clinical appropriateness for delivery by audio only. And we're able to release our first memo out to Vermont Medicaid participating providers indicating that new patient, established patient, and psychotherapy procedure codes would be covered and reimbursed at the same rate during the state of emergency, as long as they were submitted to Vermont Medicaid with a specific modifier that is specific to Medicaid. And it was available for us to indicate as being the service delivered by telephone or audio only. And then requesting that the claims also be submitted with a place of service code of 99 or other. And that's really to be able to identify that it was not delivered in an office setting or through telehealth. And so phase one was really launching that guidance as soon as possible. We released it on March 18th and convened a provider webinar on March 20th, where we had upwards of 250 providers and practices call in to hear what this new approach would be and be able to answer questions. For any providers who may be listening who called in to join that webinar, I will acknowledge that we had audience muting issues. And so it became a little bit chaotic with other people having conversations and us not being able to mute it. But what did result is that we were able to aggregate a lot of questions just from that first interaction and be able to produce our first frequently asked questions document that we could then post to the DIVA COVID-19 website and answer some of those immediate concerns in a very efficient way. And so that process has now continued since we first released that first guidance on March 18th, and we've been continually updating it. So we've been able to review and create reference charts that providers can use to look at what services we've essentially pre-approved to be submitted with that V3 modifier and 99 place of service code to indicate that they've been pre-approved for delivery by telephone when medically necessary during the emergency. And we've expanded it beyond just that new patient and established patient office visits and psychotherapy to include choices for care, home health, hospice, occupational therapy, physical therapy, speech therapy, and a lot of other services. And so that work has continued with feedback from providers, from provider associations, and we're continuing to encourage our providers to call our provider services line with recommendations. And those recommendations are then aggregated and come to the multidisciplinary team within DIVA for review. And as soon as we have a new set, we update that reference list and guidance and post it to the website.
Is somebody wanting to, I hear a voice, maybe it's just a background voice, but thank you, Nissa. That's really complete. And it's also very clear, at least I found it very clear.
Thank you.
Did you want Hillary to add anything to this?
Hillary, do you have anything to add?
No, I think you covered it. Thank you.
All right, good. My suggestion is, I think you have maybe a link to your website with this information that would be helpful. I
actually have an entire presentation to send over to you that includes all of the updated links, including not only to the main DIVA website, but I've also included the direct links to the provider guidance, the reference chart, the frequently asked questions document. And we also have some initial data if you happen to be interested in it today as well.
That would be helpful. Anything you have, please send over to Nellie and Demis and we'll put it up on our web pages. I'm not going to ask my question now. I might shoot you an email later. Because I don't want to take any time. All right. Thank you. Very comprehensive and really appreciate the time you've taken to bring us that information. So we're going to move on. And I think if you're available later on, there may be questions, and I don't know what your morning is like. Maybe, okay. All right. Sebastian Arduengo, you are here and your son is with you or not?
He is with his mother right now doing tummy time.
Oh, good. All right. Well, we're glad you're here. Sebastian, you've heard the testimony, and I guess Jen has gone through and reviewed the rules that we received from DFR, and I know you had a huge role to play in the development of those rules. I guess a question I would have for you is maybe sort out for us some of the concerns that have developed from your perspective while the rules were being developed. If you can do that, and I don't want to change your stream, so if you have prepared comments, go right ahead.
Sebastian Arduengo, Department of Financial Regulation. And I think when we were developing the telehealth rule, our main concerns were ensuring that providers were reimbursed for services provided remotely, with social distancing being a big part of the fight against COVID-19. And we were also concerned with making sure that the services that were provided remotely were clinically appropriate to do so. So a lot of the questions raised early on were with providers such as physical therapists or chiropractors be able to take advantage of the opening up of telehealth and audio-only telephone services, and our answer was generally no for so-called hands-on services. To the concerns that Jen raised about the store and forward provisions becoming effective on May 1st and then becoming ineffective later in the year when the state of emergency is lifted, and then coming back into place on January 1st, 2021. We had considered that, but the overwhelming response that we got from the provider community when we were drafting the rule was that the store and forward provisions in Act 91 were what everyone had agreed to. So it was better just to implement that now. And we've been assured by our carriers that even if there is a regulatory lapse between when the emergency rule becomes ineffective and when the original effective date of Act 91 becomes effective, that there won't be any gap in coverage for those store and forward services. And then finally, there was a question about whether services like FaceTime could be used for these services, and the answer is yes. So FaceTime would be a telehealth service, meaning that it doesn't meet all of the requirements of telemedicine, and the only reason that we can use it with respect to this rule is that the federal government announced enforcement discretion for HIPAA, which allows for services like FaceTime or WhatsApp to be used for telehealth as long as it's not being broadcast. So FaceTime could work, but Facebook Live would not work. And I think with that, I'll reserve time to answer anyone's questions.
Thank you for that. That's helpful. I'm going to ask a question now, just because I know that your time might be very short. and I'll let anyone else on the Zoom also ask a committee a question. One, were there any decisions regarding the use of the telephone going forward? In other words, are there some carriers that would support continued use of the telephone and others that would not?
I don't want to speak for the
carriers.
I'd say from our perspective, if we considered the audio-only telephone services to be an emergency measure,
Yeah.
and if we were going to implement that on a more permanent basis, we would want to do so in a more considered manner than we did for the purposes of the COVID-19 emergency.
Okay, thank you. That's helpful. Any questions, committee? Okay, we're good. Sebastian, thank you. And thanks for the work that you've done on this during the emergency. We appreciate it. And you've also had your own little emergency going on, and we appreciate the time you've taken
Yes,
from your
thank you.
family. Yeah. Okay, so we will move right on to Catherine Fulton of VPQHC. And Catherine, you've done a lot of work in this area as well. So welcome. Do we have testimony from you on our webpage?
You should.
Yep. I
Yep.
thought so. We do. So we have a lot from you. So why don't you guide us through the testimony? And welcome. Where
will
are
do.
you? Oh, there you are. Okay, gotcha. Okay.
Good morning, and I just want to affirm that everyone can hear me okay?
Yep.
Good
Yes.
morning, all, and thank you, Senator Lyons and Representative Lippert, for this opportunity to bring a status update on the statewide telehealth work group to all of the committees, and also to Demis and Nellie for the scheduling and document management challenges through all this remote connectivity. For the record, I'm Catherine Fulton, the Executive Director of the Vermont Program for Quality in Healthcare, and I'm joined this morning by Hillary Wolfley, our Associate Director of the Vermont Program for Quality in Healthcare. And our intent this morning is to level set for the committees the current activities of the statewide telehealth work group and how we started. Then we'll jump into the details of the COVID response and the really extensive work that Hillary has led in this area. And then conclude with some information on the role of VPQHC as the really expertise in systems management and an overview of our role as a clearinghouse. So without further ado, I'll jump right in. We initiated the statewide telehealth work group under our current 9416 billback funding, and it continues as an included project in the upcoming contract that's anticipated for this July 1st. We're doing what we can within the scope of that funding and those contract deliverables. We started out with the intent of supporting providers with the expansion and adoption of telehealth technology as an option for care delivery, and also for understanding population health trends through the use of analysis of VCURs and the all-payer claims data information. Initially, the focus was on what we called Telehealth 101, and it would include seminars and information on learning the technology implementation, choosing the right platforms, mastering patient engagement through a screen, preparing patients for a telehealth session, understanding billing and reimbursement to optimize revenues, evaluating barriers and uptake to adoption, flow integration within practice services, and then how to measure stated goals and the achievements. And then in March, gasoline was poured over this effort and the statewide telehealth work group was off to the races. What was of significant value was that this work group structure was in place and operational and functional at the start of this COVID crisis. And what I'd like to do is ask Hillary to provide you with some detailed information on the webinars and sessions, informational programs. God bless you, Representative Rogers. And then, and then share a detailed infographic and quickly walk through our website where we also have posted many of the documents and resources that have been shared through the webinars. So Hillary, if you'd like to go ahead.
Sure. Can everybody hear me? Okay. Hillary Wolfley, Associate Director at the Vermont Program for Quality in Healthcare. I believe we sent along an infographic prior to testimony today, so you should all have that. So I'm just going to quickly walk you through that. So just to give an idea of the activities we have undertaken since the onset of COVID-19 to assist providers with implementing telehealth under the public health emergency. I think it's useful to go over this to give an idea of the plethora of considerations that providers are having to make as they transition to telehealth and the barriers that they face. And I'd say about 99% of the organizations and departments that are giving testimony today have been involved with one or more of these events. So it's truly been a coordinated statewide effort. I see Helen's face there. She's been an amazing partner in all of this work. So in the month of April, we hosted 2 webinars. One, the Vermont Telehealth Town Hall, which was a Telehealth 101 session. Kathy went over a lot of the topics that we addressed there. The next webinar that we held was a telehealth Q&A with commercial payers featuring Blue Cross and Blue Shield of Vermont and MVP Healthcare. Both gave an overview of their telehealth policies and fielded an endless stream of questions about billing and reimbursement. Those never seem to stop. During one of our webinars, we polled the group about whether they were providing telehealth services prior to the onset of COVID-19, and almost 75% of them answered no. So this has truly been a fast and furious journey for many, especially given all of the changes you heard about this morning that have taken place and the waivers that have been put in place since the public health emergency began. So also since the beginning of April, in collaboration with the Northeast Telehealth Resource Center, Bi-State Primary Care Association, and Alpine Telehealth, we've hosted twice weekly telehealth open office hours. The purpose of these office hours is to help providers implement telehealth quickly under COVID-19. Sometimes they're open office hours and discussion and questions stem from whatever participants show up with. Others have themes, and I just want to go over a few of those that we've addressed. Those have included the ever confusing Medicare billing and reimbursement. We actually have held a few sessions regarding Medicare billing and reimbursement and have another set for this week. Federal telehealth funding opportunities, teledentistry, and a conversation with Dr. Norm Ward, CMO of OneCare Vermont, to talk about how telehealth fits under the ACO strategy and what it could look like after the public health emergency passes. Themes for office hours this week, as mentioned, you're all invited if anybody's interested. The federal billing and reimbursement, and then, or Medicare billing and reimbursement, sorry, and barriers to telehealth in primary care and chronic care management. I did want to highlight, it's not in the infographic, but that attendees at these events have included providers from across the continuum of care. And yes, Senator.
Did you say when that was happening?
Oh, yes. No, I didn't. Good question.
Okay.
So
That would be helpful.
the session tomorrow, we hold them every Wednesday, 12 to 1, and Thursday, 8 to 9. The session tomorrow from 12 to 1 will be focused on barriers to telehealth in primary care and chronic care management. And the session on this Thursday from 8 to 9 will focus on Medicare billing and reimbursement. And then more themes to come in the weeks to follow. We try to give those as far in advance as we can, but they usually come out the Monday prior. So I'm happy to distribute that information as people if
Sure,
people are
that would be great. If you send it off to Nellie or Demis, then folks who might be interested can tune in with their coffee or their lunch. Thank you.
Sounds good. Where did oh, I did just want to highlight that attendees have come from across the continuum of care. So we've had everybody from independent mental health providers, licensed alcohol and drug abuse counselors, social workers, chief medical officers, CEOs, CFOs, billers, coders, and from a variety of sites, including FQHCs, designated agencies, nursing homes, hospitals, including Small Grace Cottage to UVMMC in Dartmouth, dental practices, et cetera. So this is really touching on everybody. The bottom of the graphic includes some data on 2 websites we've set up, which I've linked to also in the PowerPoint presentation if you would like to take a look. One of them includes all of the payer resources related to telehealth changes to policy and reimbursement since the onset of the public health emergency. And then the other includes information about our events and recordings of past events. So that's it for my presentation, and we look forward to continuing this discussion and supporting the continued expansion of telehealth in Vermont to improve the quality of and access to healthcare. And I'm going to pass it back to Kathy. Thank you very much for the opportunity to address you all today.
Thank you. Thank you, Hillary.
Thank you, Hillary. And to continue on our future state aspirations for the statewide telehealth work group would include kind of a list of activities that we'd like to share so that you're aware this is going on kind of behind the scenes, and you may hear some more information from other folks giving testimony this morning. They're part of this larger work group. But we'd like to conduct a comprehensive statewide provider evaluation system with a program development that focuses on initial needs assessment and a comprehensive evaluation that will produce a gap analysis that can inform a comprehensive measurement system, including benchmarks aligned with national initiatives and metrics, and then with a tracking dashboard that will capture our continuing progress in these areas. We'd also like to expand and look for funding for subject matter experts, exactly like the expert that's providing information in the office hours on Medicare reimbursement, so we can bring the best practice and most current information and expertise into the hands of the providers. We'd also like to pursue funding to put together what we're calling connectivity care packages to reach the homes of individuals who cannot participate in telehealth sessions because of lack of equipment, connectivity, minutes, internet service plans, and provide some outreach direct to patients to enable improved access and outcomes for their both chronic and emerging care, and as an option to continuing safe provision of care through the COVID crisis and beyond. We'd also like to take on a revisitation and revitalization of the statewide telehealth strategy, a document that was prepared under the SIM work 5 years ago that has not garnered attention for a while. That could be under the purview of this work group activity to bring that alive, keep it current, and keep the what I call the constant gardening of a document like that, and produce a 10-year strategic plan for telehealth across the state. In addition, we'd like to find some additional funding for expansion of the statewide telehealth work group to include a comprehensive steering committee at the executive level, and then several sub-work group topic area specialties that would include technical assistance in education, reimbursement and policy, technical access and connectivity, data, quality measurement, and broadband access and additional equipment. We feel, well positioned with this statewide group and the current membership and expanded membership to be able to produce a statewide evaluation, including the quality measurements and data-driven improvement strategies. And as a neutral convener, VPQHC can leverage our extensive project management expertise to move the ball down the field and across the goal line to achieve these objectives. We also coordinate quality initiatives with regional partners such as the Northeast Telehealth Resource Center and others to leverage resources and funding opportunities to meet Vermont-specific needs and our unique healthcare reform landscape. So that's a brief but fairly comprehensive summary. For us, we started running a marathon race, and then in March, the pace changed dramatically to about a 5-minute mile. We're able to continue that with your continued support and some expansion. And we welcome your questions and any opportunity to respond to the committee's needs. As you stated, we'll entertain questions later, but always VPQHC is a resource to both committees all the time.
Catherine, thank you. I know VPQHC has been working on all of this for a long period of time, and the information that you have can be extremely helpful to us in the work that we're doing. I do have a question for you. It's not related to the legislation that we're considering today, but it is related to some legislation that Senate Health and Welfare has been talking about, and ultimately will link up with the House healthcare folks. We've just been working on it days when we haven't been together. And the question I have for you is, and you don't have to answer it right now, but if I can get any data that you have, that would be super. You mentioned that you're trying to track people who don't have access to telehealth, whether through connection, cell phone, or if they're using FaceTime during the emergency, or other audiovisual equipment. If you have, do you have, the question I'm asking is, A, do you have data about people who can be identified who might benefit from receiving that equipment or connection? And if you do have that, it would be extremely helpful to send it along to us. You can send it to Nellie, to Katie, to Maria Royal, and to me. I would very much appreciate it. And this is not that we're not sharing it, but it's that we've been working on this thing, and we're going to be working on it on Thursday. So let's hope we have whatever you have would be great. All right.
Yes, Senator Lyons, we do have access to that information, and we'll happily pass that along. And I'm also planning to listen on Thursday morning as well, so I'll be available.
Well, we may just invite you to be there. That would be good.
Happy
if you
to
can.
join.
Okay.
Absolutely.
Nellie and Demis can put Catherine up on Thursday just so she can contribute to our discussion. Thank you. Okay. I will let folks ask a question of VPQHC. All right. We'll move on to Helen Laban. And Helen, first of all, Helen, I want to say thank you to you for being such a leader on telehealth, telemedicine, telephone. And we're glad that you're here and can provide us with some information. Thank you.
Great, thank you. Thank you for the opportunity to speak with you. I'm Helen Laban. I'm the Vermont Public Policy Director for Bi-State Primary Care Association. Thank you, Senator Lyons, for those kind words. I'm going to rein myself in and keep it focused and brief. I'm going to give a quick snapshot of what's happening. I will say that if you want to hear more from our providers, we do have a podcast where we are posting episodes about telehealth, speaking with providers. I'm angling to be the Jane Lindholm of Primary Care Focused Telehealth podcast, which is a competition area of one, I think. And I can send along the link for those who are interested. So just to set this stage here, I want to emphasize that our providers are doing a wonderful, wonderful job in what is literally the worst case scenario for starting on telehealth. We're seeing in our members 80 to 90% of visits going to remote, which is a volume that's a lot higher than what you would normally want. Our clinics are open though, just to be clear, but the standard for an inpatient in-person visit has obviously changed with COVID-19. There was no time for training, building systems, working with patients. We had to do this immediately. And we, for a variety of reasons, were at the very beginning of our telehealth journey in primary care. It was not a really well-developed area of work yet. So now as we look at, we can frame the idea of exiting this first wave of COVID-19 response as building the system we wished we'd had in place going in. So there's a lot of focus now, as Hillary articulated, on getting those systems and those trainings in place. Also right now in this time, the patient cases may be skewing towards more complicated than we would normally be seeing due to, again, a variety of reasons, delaying care, confusion about care, just the increased anxiety and stressors during COVID-19. And also, we may not have a pre-existing relationship with the patients that we're seeing right now through telehealth. That was something that was waived under the emergency orders because we wanted to make sure that everyone could get in to seek care. But again, normally we would be looking at patients with whom we have an existing in-person relationship when we're switching to these telehealth options. So this is truly disaster response telemedicine. And I want to recognize that our practices have done just an incredible job making that adjustment, but it's not what we would have wanted. And we needed all the tools available, and that, as has already been described, there was great work done to make those tools available. And setting aside the recognition of how things are being implemented right now, we can also note that in that wave of rapid transition to remote services, that shows up the pre-existing faults in the system and the barriers in the healthcare system. And now the positive side of this is that our clinicians are beginning to think about how telehealth can remove some of those barriers and moving forward, and including using telephone-based audio-only telehealth more effectively. And a lot of what I'm going to talk about now is going to be looking at that telephone-based side of things. Well, partially because that's what I was asked to talk about, but also that's a lot of what's sort of new right now, and where we're really asking the questions about what more could be happening moving forward. And I think about it in sort of three buckets of how the telephone is being used and that audio only is being used. The first one is checking in on patients. And that's sort of unique in telehealth because it's a provider initiated call out to someone to see how they're doing. Often we would see that in care plans with chronic care management. We also see tools being created for that outreach. One Care Vermont, I know, for example, has a tool where they've put together a way for providers in their network to see who's at high risk and who might need that check-in. This isn't always, probably not even typically reimbursed in sort of a fee-for-service way. It's often reimbursed with a capitated payment type system. And then another bucket is those triage calls that Nissa talked about. And those are patient-initiated, they're 5 to 10 minute check-in. They're not connected with an office visit, virtual or otherwise. It's just to see a patient has questions, they need to know if they need to see somebody, and it's an evaluation. Anecdotally, we hear that has been a very high volume of calls, especially at the beginning of the transition over and the turnover at the end of March. We may not see in the data these show up particularly well for a couple of reasons. One is that although those codes often did exist, and then some were turned on for this, because they weren't a high volume, they weren't a standard part of what our providers were used to billing for. Also, Medicare, which is a whole nother area of reimbursement issues, has traditionally had a copay associated with those. That is not at all what is done if the commercial payers or Medicaid, to be clear, but Medicare has done a copay, which has been generally seen as, frankly, not fair. During the public health emergency, providers are allowed to waive that copay, but that's been another barrier to having in place the systems to code for this. And then also these are usually handled by RNs or nursing staff, and RNs can't necessarily bill those codes, although Blue Cross Blue Shield, I know, did in fact turn that on for RNs during this response. And And just to note, although they can't necessarily build them, that's more of a data issue. There's lots of ways to make us whole. So DIVA, for example, has their monthly retainer payments that blend a value-based and a fee-for-service system. So when I point that out, it's just, again, looking at that data, we may not see the high volume that we think there actually is for these calls. And again, this, like the checking in on patients, again, it does sort of bear the question as we look moving forward and think about how we reward using the full suite of tools available to connect with patients. How do we support this in a reimbursement sense? And again, many of these do then fall into the bucket of things that we see with capitated payments, value-based payments, global budgeting type systems as a way to have a holistic approach to engaging your patients. And then the third category is the audio-only telemedicine. And that's the special option that's being called out in particular at this time. And that's where typically we would have that platform only be an audio-visual real-time interactive video. But during this emergency, as has been discussed, the audio-only telephone has been turned on. And that's where we get more nuanced, right? When you talk to physicians, they're not in love with using audio-only telephone as the best way to provide medicine, all other things being equal. But of course, all other things are never equal. And so they are very enthusiastic about this as a way to reach patients who might not otherwise be seen. And right now it's a big emergency. So the people for whom the risk of going into the office versus telephone care is a much bigger group of people who fall into that cost benefit analysis of let's do this by the telephone. But I think it's really important to point out that the world is full of hidden emergencies that have always been with us and they always will be with us. So, I lose my license, or I'm a single parent and my childcare falls through, or I get sick and now I have a compromised immune system and it's annual flu season, right? There's a lot of hidden emergencies out there. And clinicians want to be able to reach these patients. And often they may not have access to other ways to have that medical care. And it's not just about the physicians being reimbursed. I want them to be reimbursed. But it's also a way of building the system that serves all patients, right? So if you're someone who thinks there's no way to get physically to an office visit and you don't have a fancy setup for telehealth, and you think that that means you can't get care, then why pick up the phone in the first place, even to ask or even to check in? And on the clinician side, if telephone isn't officially recognized as a way to deliver care, then where are the training systems for best practices? How do you train clinicians in using this tool? So the idea of continuing to reimburse telephone is not just about the payment for the audio only, but it's about giving that tool and finding the best way to integrate it into our broader toolbox on serving patients. And probably leaving COVID-19, it will be a really small part of overall care, but it's a really important one because it's that bridge to healthcare for folks who might not otherwise have a bridge. And so that's why we see that as a really important thing to be able to continue on. We think there's going to be a variety of lessons learned from this. There already are. And well, I was already excited about it. I'm excited about learning from these and building on them. But that telephone audio only is definitely one that's being held up as a major point of learning for us right now in this. And so it's an important one to consider. But I'm happy to come back at any time to talk about any of the many options that we have in telehealth and how it's being utilized in primary care. And I really appreciate this opportunity to have the conversation.
Thank you. This is terrific. And it sounds like the issue that we're hearing about is the continuation of telephonic communication, audio only communication post emergency, and how that can provide some access in some way. So is this a question of understanding, Senator Ingram?
It would be for Helen. So I just wondered, Helen, if you could maybe give some examples of what can be done audio only that's not just triage. I mean, it seems scary to me to think that a physician can't actually see the patient. And what are they able, I don't know, is it like a respiratory illness and they can prescribe medicine? thing? Could you just give me some examples?
Sure. So often it's being used in like a continuity of care issue. You know, there are issues that probably we can all think of that we have in our own lives as semi-recurring health issues where we check in and maybe it doesn't need an office visit. Often it's used in mental health for providing services there. It can also be used, we're finding, it's interesting how different people are using it. So we talked to dentists, right? You wouldn't necessarily think that a dental visit would be able to be done by telephone, but when a lot of the need is informational and asking questions and understanding what the issue is and giving options for treatment, even the dentists are being able to use a telephone for it. So we're really finding a broad range of applications. And remember, it's not necessarily, you know, there's a difference between triage as in it's a 10-minute call and you never come in again, and triage as in we think that you can manage this at home for the next 6 months, and after 6 months come in and see us. So even though during COVID-19, during this short snapshot in time, we're thinking about an either or sort of thing around telephones, in reality, how it I think plays out or would play out normally would be as a blended option between delivering things by telephone and reducing the number of times you need to come into the office, not eliminating the number of times.
Thank you. That's helpful. Good. I forget when you are around medical people all the time, so some of these things seem second nature. So it's nice to have those examples. Thank you. All right. Any other questions of clarification? Good. Helen, thank you so much. And as you have heard, Senate Health and Welfare has been looking at some other related issues, but so I might shoot you a little email, and Nellie may actually invite you to Zoom with us tomorrow. Not tomorrow. What's today? Tuesday? Thursday.
Who knows?
Who knows what day it is, right? That's right.
I'm happy to provide any information. Thank you for the time to speak.
Thank you very much. All right. Representative Smith.
Thank you. I have a couple of questions and I don't know who to direct them to. So if anybody wants to answer them, they can, but I'll read them and then we'll see where it goes.
Can I make a suggestion?
Certainly.
If there are general questions going out to a number of folks, let's hold those questions until the end.
Okay.
And because I think we're all going to try and do that. I've been trying to only ask questions specific.
Okay, that'll be fine, Senator.
Okay, you know, I don't like turning off conversation or
Oh,
questions.
that's fine. I'll wait. I've got them written
Hold on,
down.
Tom. You're first in the queue. You are number one. All right. After Bill. Okay, Jessa, you are here, and Jessa with Katie Marvin, and I know that Katie is available, Dr. Marvin is available at 11:30. Do you want to wait until she is she on with us? Let me just check my other screen. Not yet. So Jessa, are you here? Yes.
I am here, yep.
Okay, do you want to go ahead right now, wait for Dr. Marvin, and we would go ahead to some of the healthcare provider carriers.
I'm happy to go ahead now. Our testimony is somewhat independent, so that's
all I want to
fine.
know.
Sure, thank you for asking.
Senator, I think Katie Marvin may be on the screen. At least it's on the screen I see.
Hi there.
Dr. Marvin.
Hi there.
Welcome. All right. Well, we're going to get you in at your is it before 11:30 that you need to testify, or at 11:30?
No, I'm completely free from here on, anytime.
Oh, good. All right. Terrific. So we'll let Jessa Barnard go ahead with her testimony, and then we'll invite you to offer yours.
Thank you.
Thank you for being here.
Thank you. Thank you, Senator Lyons and Representative Lippert. Appreciate the chance to be in front of you. Jessa Barnard with the Vermont Medical Society. We represent physicians and physician assistants across the state. And we really do thank you for your interest in telehealth services, and think it's very good timing to start thinking about what aspects of telehealth and audio only services we can continue to support and grow through the next 12 to 24 months and beyond. And I think one point I just want to highlight before going into the rest of my comments is that there may be a disconnect between a declared state of emergency in Vermont and when we still need to provide care differently. You know, we don't have clarity yet from the administration, for example, in terms of how long he's going to leave a declared state of emergency in effect, which is some of the triggering factors for both provisions in Act 91 as well as other regulatory flexibilities. So it may be that the administration, we've sort of gotten through the worst of the worst, and we may no longer be in a declared state of emergency, but we may still be trying to provide care differently, keep social distancing, keep patients out of the physicians' offices and hospitals if we can, if it's appropriate to provide care that way. In fact, you'll see in the guidelines, which I'd be happy to talk to you about on another occasion, that just came out yesterday for resuming some elective non-urgent medical procedures and visits, that one of the provisions is in that guidance is to continue to provide services through alternative means as long as sort of possible or appropriate. So we would like to ask the committee to make sure that the flexibilities given in Act 91, both for licensure and telehealth services, continue at least through June 30th, 2021, because we don't know how long the official declared state of emergency may last, but we expect that this pandemic and this virus will be with us for the foreseeable future. And so we do think we'll need the flexibility to provide services remotely for probably 18 months, if not more. And then the other piece we would like the committees to consider is what's come up this morning, the reimbursement for audio-only phone services, which we think are really an important aspect of providing care and providing equitable care to Vermonters across the state. So we have recently begun a survey of our members regarding the strengths and drawbacks of telehealth. This was actually partly in conjunction with VPQ-HC. You just heard that they are trying to gather information about implementation and also the need for these patient care packages, whether patients need more services or more technology in their home to be able to participate in telehealth. So we sent out some questions to our members. We've only had some minor responses yet, so I'm not sharing the full results with you until we hear from more of our members, but of those we've gotten to date, 66% reported being able to implement telehealth services to the full extent that they hoped. And you'll hear from Dr. Marvin. One of the reasons we invited her to join this morning is she has some really great stories of how it's been helping and how it's been serving patients. But some of the comments we've received from the survey were reducing patient driving time and expense, having visits be more relaxed with richer dialogue. Some patients really feel more comfortable being in their own space, regardless of whether they need to or not. It's actually been facilitating care. And then also, there may be patients, for example, teenagers who may be really much more comfortable talking over technology. So I'll let Dr. Marvin elaborate more about that. And then to add that despite this amazing and very quick transition that you've heard about, all of our survey respondents also did share that there have been technological difficulties in implementation, largely around patient connectivity. And we know Senate Health and Welfare is very interested in this issue around broadband access or low bandwidth or lack of Wi-Fi altogether. And then also lack of technology in the home. So patients not having phones or laptops, difficulty installing software, lack of equipment. So those are some of the areas we are hearing about, and that's why we're very excited to be partnering with VPQ and seeing where their project leads in terms of possibly getting some of that technology into the home. And it's also the reason we think audio only is a really important option. One of the respondents said that due to those sorts of issues, up to 50% of visits that he or she, I'm not sure if it was a he or she, try to initiate with a patient over video technology end up converting to audio only. So the screen may be freezing, the audio may not be working, whatever the issue may be, they're then deciding this is not working, let's go on to the phone. One of the other concerns we were really hearing until CMS changed its position last week was the limited number of services and low reimbursement for audio-only Medicare services, especially, that's a population that in Vermont probably has particular lack of video capability in their home. And so that was and people who are most at risk of if they get COVID. So that was a very big concern to our members. We're very appreciative that CMS has made some expansions in the past week. So just in conclusion, that's one of the reasons VMS strongly urges your committees to continue to require insurers to provide coverage for audio only visits. We do acknowledge not all visits are appropriate for audio only, and the determination that any visit can be provided over remote means needs to continue to be based on the clinical judgment of the provider. And our members are being very creative. They're even splitting visits. Some part of the visit may be over phone or audio. Some may be coming in, particularly, for example, around pediatrics, they're having kids come and get their vaccines in the parking lot, but they're doing the rest of the visit remotely. So there are ways of being really creative. And we think that the coverage flexibility and coverage requirements have been really important in facilitating that. So that was the testimony I had. I'll be happy to send something in writing after we're done this morning. And please don't reach out if you have questions down the road.
Thank you. It would be great to have your testimony, in particular, your recommendations for what we might do to continue or analyze how to continue what's going on right now. I mean, you also mentioned, we haven't talked about it today, but you did mention the extension of licensure flexibility until June 2021. Well, we'd have to hear from other folks regarding that. And then also your comments on audio only and what kind of working group would we have to put in place to have provisions? What should we be doing there? Anything you can offer on that end? And this actually serves other people as well. What they're thinking about would be great. All right, thank you. Senator Cummings.
Just Senate Finance is very interested in broadband and availability. And we're looking for some maps, some areas where there are particular problems. So that if we can get some money, we might be able to get some connectivity in those areas. So anybody that has any kind of clusters where there's issues, if they'll get it to me, we'll see if we can do something.
So Senator, just so you know, that is exactly the information that I've reached out to ask for, and and remember the work that we did with Maria Royal. So I think that between the two committees, we'll actually now 3 committees, but 2 committees will be able to put together some legislation that does look at funding access for all the things that Jessa has been talked about in terms of patient access. So let's talk. We'll do that. Yep. That's what Maria Royal is coming in with.
Well, Maria has the funding sources.
Right.
But we have a plan to do the whole state. But if we're looking for our smaller clusters, so we're really looking for.
That's exactly what we've just asked VPQHC and Helen Laban for, and others for, so that we can determine where those providers are. And then it's between the provider and the patient. So it makes it an interesting linkage. Good. Maybe we should talk later.
I'm booked till 6 o'clock tonight.
Okay,
so
well, let's not talk until tomorrow. That's okay. All right. Sorry for the interlude there. You can see what happens when everybody starts working together. Everybody wants to do everything, but we will do something here. Dr. Marvin, thank you for being with us. And Jessa, thank you for your testimony. I'll look forward to hearing the rest of the survey, in particular the patients who don't have access and the providers who are linked in with those patients. So maybe my goal in our committee is to work out a system for identifying those folks, and then how we help providers apply for the funds that are available. And we do know that there are funds available for providers and their patients. Okay. Dr. Marvin. Thank you for being here. And I see that you do have testimony on our webpage, so why don't we let you present your information?
Thank you. Can you hear me okay? Yeah.
Yes.
I was also thinking actually what you were just talking about broadband holes around the state. These schools that are all doing their work remotely might also have information
Yes.
pertaining to different kids and families. It might just be another way of searching out those pockets.
And not to take us on another track altogether, but recently I did hear from the Children's Hospital. I will just say the Children's Hospital is very interested in that particular sort of vacuum to have kids and families receive health care within the school itself. It's been very helpful. So
Yeah.
we could go, just to go back to one of my favorite John Muir quotes, when you try to separate one thing out, you find that everything is connected.
True.
And we wish it were in this state, right? With broadband. Anyway. So go ahead, Dr. Marvin.
Thank you. So I'll just read the testimony that I sent last night. So I'm just really grateful for the chance to present today on the importance of telemedicine and just how it's moving forward in our clinical practices. And I'm speaking on behalf of myself, other doctors with whom I've been speaking with across the state, and also as a member of the Vermont Medical Society. So I support keeping the flexibilities under the COVID emergency bill, the 742, at least for the next foreseeable future, as Jessa said, and also to ask for formal requirement of reimbursement for phone-only services, and we can go into that more. I was just going to quickly tell you what things looked like for us before telemedicine was approved, and then how telemedicine has really benefited our community, especially providing opportunities for the highest risk patients. In short, it really has been one of the silver linings of this whole experience, as hard as it's been. So I work for the Community Health Services of Willamette Valley, which is an FQHC, or federally qualified health center. We serve, I'm not exactly sure of the numbers, but somewhere in the $20,000 to $25,000 patient ballpark in Lamoille County, of all ages, birth to 110, I don't know. In mid-March, our office numbers just plummeted down to about 50% of normal. Our dental office had to close. Pay cuts and furloughs were necessary for all of us at a time when the community needed us the most. And our daily phone calls, which went from usually around 400 per day, surged 1,500. Patients were really afraid to come in. Our staff were afraid to be there. And literally the rules changed every single day. And through that stress and sort of ever-changing policies and our own fear for sort of our personal safety and family safety, we were just continuing to go to work every day and trying to figure out what to do next. And really, there was no playbook. And we really answered every single call that we could, from those that were worried and those that were truly ill, and of course, people that were just stressed beyond belief. Most of which we could manage over the phone, and some of course had to be seen, and we would bring them in for a visit. Some did, but in an 8-hour day when I usually would see 22, 24 patients, I was seeing 4 to 6, and then spending all the rest of my time on the phone. And then of course into the nights when we would be on call, taking 25 phone calls a day on the weekend or more, when we normally would just take a handful. So since televisits have been implemented, we have the capacity to use a HIPAA compliant platform called Fuse, which has both video and audio link. And if that fails, as Jessa said, we resort to the phone. It's been a really big game changer, both for our patients and also for our organization. And also, Jessa said, there's just certain things we have to see in person, and we do have the office open every single day for those things, like fractures, lacerations, IUDs, vaccinations, but many things can really be managed with telemedicine, and our nurses are becoming experts on triaging these phone calls into the appropriate category. Currently, we're seeing about 2/3 of our visits in telehealth, 100% of our behavioral via telehealth, and the populations that are benefiting the most are really the most vulnerable, as I said, the elderly, the underserved, patients with mental health needs, and the actually sick. And I was just going to talk quickly about each group with some specific examples. First, the elderly. So patients with diabetes or hypertension are just terrified to come to the office because they know that those are risk factors for COVID. But they're at high risk of having unmet medical needs resulting in heart attacks and stroke. And there's been a lot of information in the press about just deferred care during this time. So telemedicine has really helped provide a bridge for those patients that really shouldn't be coming in. And especially if they can provide us with home blood pressure readings or glucose checks, then we can really do most of a visit right over the phone or over telemed. And for chronically ill patients with like COPD, emphysema, cancer, really managing them at home is the right thing to do. Since many of our Medicare patients do not have the internet, and I could try to do an impersonation of some of the things that they've said to me about this, the video call is just impossible. So we usually resort to phone care for many of our patients in the Medicare population. Again, highest risk, most likely to not come in, and most at need for this care at this time. So we are extremely grateful for the changes that have recently taken place to make these calls reimbursable. This is very necessary. Also sort of in the same category are, and also vulnerable to COVID, are the snowbird patients that are returning to Vermont from the South. And with telemedicine, it really opens up some doors to manage their care while they're away, even next winter when they go back, providing some consistency and maybe eliminating the need for them to have an entirely different set of doctors down in Florida. But we can also just virtually check on them during their 14-day quarantine, assuming they're doing that when they get here. And we're hoping that they abide by those, but keeping them at home, being able to check on them, and not requiring them to come in the office during that quarantine would be really important for us. Number two is the underserved. Many of my patients drive an hour to the clinic, oftentimes scrambling to pay for gas. They have a hard time figuring out what to do with their kids if they're a single parent. They can't leave their kids at home, but they don't really want to bring them in. So rural poverty, unfortunately, really overlaps significantly with my medication-assisted treatment population. I have about 75 patients who I see for buprenorphine prescriptions at least monthly. And with the stressors of unemployment and homeschooling, being able to provide them with a telehealth visit has been a huge sigh of relief for them. So they visit us from their homes or during a break from work, and I can talk to them, feels face-to-face. We hear about the lives, their stressors. We reassure them that we're not going to lose them. We're not going to drop them. They continue to go to counseling also over televisits. I mean, in fact, I just got off the phone this morning from about 7 of these visits that I've done just from our administration office. And it's been a very seamless process. Some patients, of course, need to come in who are newer to recovery, and we need to do a more face-to-face and more urine monitoring of their testing. But for the most part, the patients that we know really well, who've been taken care of for a long time, we don't have to have them come in every month. 3 is mental health. As noted above, our MAP patients are meeting with their counselors over telemed, and our entire behavioral health and wellness group has been doing all of their work online. And this is both for safety and convenience. The patients are getting great care, especially right now when so many patients are really struggling with the stress of all of this. It's untold what kind of trauma we're going to be seeing in the months and years to come, I think, both in the adults and children, really. So I've had more patients sort of present with self-harm thoughts, unfortunately, too. And just the other day, I was in the clinic with a woman who was really having a terrible week, and was able to actually bring up on my computer one of my behavioralists who is on call basically for this exact thing. And she was working remotely, but I was able to bring her up on my computer to join us in this conversation, even though I was face-to-face with the patient. So it just provides so much access, potentially life-saving. Similarly, I have some young patients who are just out in college, and some of whom are struggling with their own mental health and depression. And I'm visiting with one particular patient who lives in Pennsylvania, and seeing her monthly. These are pretty complex and high-risk visits. They can take up to an hour or so, frequent visits. And so we would, as we always have, do them for free because we know them, we're their family docs, but being able to turn it into a reimbursable visit really makes sense and is good for their company. So as a family doc, my office has about 8,000, 10,000 patients to whom we promise 24 care. And we've taken calls all hours, 2 o'clock in the morning, Christmas morning. And we will continue to do that as we always have. But because these calls can become very complex and time consuming, telemedicine's also just opened up an avenue for us to be reimbursed for some of these very complex situations at any hour, regardless of where we or our patients are located. And then lastly is the acutely ill. We've had a handful of our own patients who have tested positive for COVID, and so far have not had to hospitalize any of them. They've all been managed at home by us using telemedicine and phone calls. If the patient has a good video connection, a thermometer, a pulse oximeter, it really helps us keep them out of the hospital, thus reducing unnecessary exposure if the patient's stable enough to be home. But having that video connection and being able to reimburse, again, for a pretty complex high-risk visit is pretty important, certainly cheaper than a hospital stay. Now, here's sort of like what I'm thinking about for the future. It's a little unknown and unfortunate, but the COVID cases are likely to wax and wane, I think, for months, maybe even 2 years, and it's really unclear. So I feel like we need to be able to use all the tools possible to serve these patients and to protect both our staff and ourselves. Televisits are a really important part of that. The learning curve has not been comfortable. Some patients, some providers really do not like it. There's not the human touch that we are used to practicing. There is terrible bandwidth in a lot of towns. It's not perfect, but we've also only been doing this for a month. So we're learning some tricks, like we need to have that connection established. We need to have our front desk really troubleshoot that before it gets to us. We need our nurses to do what we call virtual rooming, where they get the patient up and do as many check boxes, record any vitals or blood sugars or blood pressures in the chart before the provider gets on with that call, so that it improves efficiency. And then, so we're still in this learning curve phase, I believe, and we're going to get better and better at it. But bottom line, it's way better than no care, especially in a country where there's just so much chronic disease that we cannot let go unmanaged, as well as mental health needs. So it's really helped bridge that. So, as I'm sure you all are as well, we're worried both about the economic and emotional health of our community. Primary care offices are really at ground zero for all this, and the rural primary care workforce shortage that I testified to some of you again about a few months ago it's really still a looming crisis. And I'm actually sort of worried this was going to worsen that blow with the damage that's happening right now to organizations like ours, private practices, and even just general burnout. But any kind of meaningful change that we can implement and continue to support them is going to make a huge difference. And so telemedicine is really an important start in that direction. Our most vulnerable patients will really benefit, and it will help our organizations, and it will probably also be better for the environment. So that's what I had prepared. Thank you.
Thank you. That is very comprehensive and extremely informative. So I think we're all on the same page in terms of improving patient access. It will a lot of ancillary benefits both to the patient and to the provider. So we appreciate your testimony a great deal. And it is about the provider-patient relationship and how that can be improved utilizing technology and improving access to technology. So thank you.
Thank you.
All right. So we're going to move along, and I know that there will be questions for folks or from folks. So let's, but we'll get there. And I know that Representative Smith was it Representative Smith or Representative Reed first in line? I thought so. Okay,
Smith.
I got it. After Representative Lippert. So we're going to move on to folks representing various private carriers, and we'll start out today. Susan Gretkowski has the honor of going first. So welcome, Susan.
Yes, thank you. Happy to anytime. MVP is in full compliance with all of the emergency rules and all the guidance from DFR, which is what I testified to last week. So we are covering expanded telemedicine and telehealth, store and forward, and including audio-only telephone at the same reimbursement rate. And even before the COVID emergency struck, we waived cost sharing on all telemedicine to try to encourage and incent members to utilize that service. We are allowing physical therapy, occupational therapy, speech therapists, and athletic trainers to render services through telemedicine and telehealth. There was some question about that in the beginning, and of course, mental health as well as all physical health. So again, there's no cost share for members for any COVID diagnosis, treatment, or preventive services. And to be honest, I think we're all still working on exactly what is the scope of what's a preventive service. So, we're in touch with the provider communities. We're in touch with DFR with this. DFR has been hosting a weekly COVID call every Monday. And so it's good because there's a broad range of people on that call, and a lot of good ideas can get aired or issues can be talked about during that. One issue we have seen is with store and forward. Apparently there's some confusion with some providers about exactly how to code it. Apparently there are different codes to use for this. So we did have an example with a dermatologist, and his claim was denied. We reached out to him and worked with his office, and we haven't had any problems since. So we're really doing two things on that front. One is having our provider relations staff reaching out to provider offices to say, hey, make sure this is the way you're coding. But also we have what we call a fast fax, which we've had for years. And this is our primary way of communicating with providers on any kind of updates, not just anything COVID. So that has been going out more frequently, including there was one that went out yesterday, more specific about the coding. So what I think you folks want to hear about maybe the most today is, what are we going to do with store and forward after the expiration of the DFR emergency order, but before January 1? And we will not turn that off. We will continue the coverage just as it is today for, I think, a few reasons. I don't think COVID is going to just turn off. So we want to make sure that people can get the care in the best way and safest way possible. But also, just practically speaking, from an internal systems perspective, it's really kind of a pain to, we reconfigured the system, then you don't want to have to unconfigure it, then reconfigure it back in January. So it's just so much easier for us to leave that on. So we are definitely leaving that on. So, which is what Sebastian said. The other issue is really audio-only telephone services. If this would need to become permanent, how would we handle that? So this is something we've been talking about on these DFR COVID calls. And we are in agreement with DFR that if this is going to continue on a going forward basis for whatever reasons, we would all have to evaluate which services are really clinically appropriate for this, because I think, even the providers have told us there are some that are not. But we have committed to work with DFR in coming up with, putting a definition around what would be the most reasonable scope of services to continue telephone only. Because my sense is it's going to be a while, before we can safely move away from something like that. So I think, after the state of emergency is lifted, it really is going to be a work in progress to see how, how we're doing as a country with COVID and all of that, and then just responding. So we obviously want our members to be able to get their care in the safest manner possible. So I think that's what you wanted to hear from us today. And And again, I'll be around for the rest of the call if there's any questions.
Thank you. That's very helpful. And that is exactly what we wanted to hear.
Yep. Okay.
Maybe not the content. We don't know. We'll have to wait and see what people, how valued it is, but I think I value it very much. Thank you.
Okay.
All right. Sarah Teachout is here.
Great, thank you.
There you are. Welcome.
Thank you. I'm Sarah Teachout with Blue Cross and Blue Shield of Vermont. I won't repeat all the testimony you heard before about the expansion of telehealth, but we did everything that was required, and I think added some services beyond what was required by the Department of Financial Regulation. We've had largely positive feedback from providers and patients about the use of telemedicine, and we felt like during this crisis, it made sense to allow as broad of access as possible between patients and providers. We don't know when we'll return to a more normal situation, but as we consider extending these telemedicine services and access, we think that we need to balance quality as well as access to care. And we do have some concerns about how telemedicine, specifically the telephone-only phone calls, can be used going forward. A second piece that I know that our senior medical director has some concerns with is allowing preventive care visits for children under the age of 2. It's something that we did in this emergency and felt that needed to happen. But she, as a pediatrician, feels that there should be some more clinical direction around that piece. And then the telephone triage calls, which were also an emergency implementation. I think we'd like to talk further about what needs, how long that needs to go on for. And then I think the last thing, the point I would make about the telephone only visits, besides talking more specifically about patient quality and clinical effectiveness of those, is that we currently pay at the exact same rate as an office visit or a telemedicine visit for those telephone calls. So that's something that I think we should think about if we're moving forward. We don't believe it's the same quality of care as a telemedicine visit or an in-person visit. And so I won't expand on that much more, but we've been working with the DFR working group. Dr. Kate McIntosh is very involved in this and talking about it internally. And I wasn't able to get her here today, but if you'd like to hear her perspective, I can arrange for her to speak to the committees in the future. Thank you.
Terrific, thank you. And just as we've just heard from Dr. Marvin, some of her comments suggested that sometimes, and I don't mean all the time, but sometimes the telephone is value added. So I think it'll be fun for the DFR to continue its calls and have those conversations so we can sort this all out. Thank you. Tiffany Pierce is here, as well as Christine Cooney, both of Cigna Healthcare. Do you have an order to your testimony? I'm looking for you on my first page.
This is Dr. Pierce.
Welcome.
Can you hear me?
Yes, we can. And are you speaking on behalf of Cigna?
Yes, I will. If you don't mind unmuting Christine Cooney as well as Peggy Roop, that would be terrific.
That's just fine. Thank you. Go right ahead.
So, thank you very much. And thank you for the committee's time. For the record, my name is Dr. Tiffany Lingenfelter Pierce. I am Cigna's New England Market Medical Executive. As I noted, I'm joined today by Christine Cooney. She's our Cigna State Government Affairs Manager in New England. Also by Peggy Roop, our State Regulatory Manager for New England. The information I'm referencing and much more extensive information can be found at cigna.com/COVID or cignaforhcp.com. I want to recognize at Cigna, we really appreciate the doctors and nurses here in Vermont and across the country who are working on the front lines to offer dedicated care for our customers to help protect our local communities. We know that it's very important at Cigna to be committed to our customers' health and make it easy as possible for the doctors to focus on delivering quality care safely and efficiently. I want to give you a couple of highlights. At Cigna, we're waiving customer cost share for COVID-19 screening, testing, and treatment through May 31st, 2020. Similarly, waiving customer cost share for telehealth screening for COVID-19 through May 31st, 2020. We're reassessing as we're coming closer to that date, our continuance of that guidance. Cigna is also looking to make it easier for our customers to be treated virtually for routine medical care, inclusive of other services like physical therapy, occupational therapy, speech therapy, as well as behavioral health services, inclusive of IOP, partial hospitalization, some ABA services, and some behavioral health inpatient services, those by their local providers using their usual billing codes with a modifier for standard reimbursement. There's also been reference to e-consult or the store and forward process in place. For Cigna, we understand that that's a state mandate in Vermont, and what we're looking to do is go back and adjust reimbursement back to March 13, 2020. A question was given about interim to January 1st, 2020. We're continuing discussions as we're building this out as a national initiative and had looked to pilot before fully implementing our reimbursement process. But note, again, that will be compliant with all state mandates. Virtual care for our Cigna customers is also available through MD Live and Amwell. That's both for medical and behavioral urgent care services and ongoing behavioral health treatment through MD Live. We also recently just rolled out teledentistry for urgent services for our customers if they're unable to see their own dentist. So we want to thank each one of you for your partnership in addressing the COVID-19 pandemic. We're continuing to work with the doctors and nurses here in Vermont and nationally to proactively work together to develop out a strategy to improve the care for our Cigna customers. Thank you. I'll take questions, I guess, later if you have some.
Thank you very much. Just to clarify that you are following state guidelines, rules, regardless of the state that you're in. So in other
Yes.
words, yeah, okay,
State
thank you.
mandate.
Right, good.
Thank you.
All right. And just so folks know, I have added Representative Chena to the list. So we have Lippert, Smith, and Chena. And anyone else who wishes to add themselves onto that list, go right ahead. And last but never least in our testimony today is Jill Olson. Jill, thanks for being here.
Thanks so much. Can you hear me okay? I'm using my phone audio.
We can hear you
okay,
beautifully.
great.
Yeah.
Okay, so my video could cut out. It's pretty bad here at my house, but the audio should be fine because I'm doing it through the phone. Thanks so much for the opportunity to testify. I'm afraid I didn't have the opportunity to hear all the other witnesses, but I think I'll be able to just add some new information, and I'll try not to repeat what I think has likely been covered. Let me just start with a little bit of an explanation about how home health provides any services remotely, because I think that there's some surprise and confusion about that. So I just wanted to start there. So there are some types of services that actually we found are lending themselves pretty well to a remote service. So one of those is case management for Choices for Care. So when this crisis began, Dale quickly asked us to move all case management to some kind of remote tool, either a telephone or video. A lot of it is happening by telephone because of the lack of broadband in many of the communities that we're serving. So that's an example of a service that we're now providing through a remote mechanism instead of in person. But there's actually a lot of work that we can do that's blended, and that's actually how I think a lot of the telehealth and home health is working probably the most seamlessly. So one example is maternal child health. So we have maternal child health nurses who might go and do a home visit to help a new mom who's struggling with breastfeeding, and to do an in-person visit and really provide that assistance in the home in person, where really you need to be there, you need to see what's happening. But subsequent visits might be just fine over video or over the phone for that follow-up. So we're doing a lot of that blended work. In our episodes for some of the older folks that we take care of, people with multiple chronic conditions who may be coming out of a hospitalization, again, it's often going to be blended. So the nurse aide has to be there in person to help with the groceries and the bathing and the food preparation. But the PT maybe can do an initial visit in person, do an assessment, but then do some of the visits remotely. And so that's really how it's working in home health. It's a lot of blended care because, of course, we serve people over and over again most of the time when someone's on our service. I wanted to also just make sure that the committees both know that right now in Vermont, there are 40 COVID positive patients on home health service. So we're actually caring for quite a few more COVID positive patients in the home than are being cared for in hospitals right now. And that's been true for several weeks. So the highest we got to was about 47, but we've been at 40 for several weeks. So I just wanted to be sure that people knew that we're providing direct care to people who are COVID positive. I'm not sure that that's very well known. Nope. So in terms of telehealth, so what's working great is actually how things have been going in our state. So we've gotten plenty of flexibility from the commercial payers. We don't have a whole lot of commercial business, but Medicaid has also been really helpful, and we were able to very quickly identify codes that were appropriate for telehealth. We had no disagreement at all. We actually came to agreement really fast. And because of the way we bill, it's been great. We actually didn't even have to change our billing systems. So we just bill for the visit, whether it's in person or not, and that's been working just fine. So we're really grateful to DEVA for their quick response on that. We do have some significant gaps. So I think there's still a lot of room for us to do more work on telemonitoring, which was something we were talking about before this all began. And that's really where we have we have machines in people's homes that help them track key vital signs, including blood oxygen levels, which are, as anybody who's reading the paper knows, is really important for COVID positive people. So that's a way for us to have, to have a nurse taking a look on a daily basis on how someone is doing. And so we actually, the Vermont Community Foundation actually gave grants of between $5,000 and $10,000 to every agency to help purchase more telemonitors, which in my view, as we head into the next phase, we're going to want more of those. I really think we're going to want more of them. So that's still a gap because there's not a whole lot of coverage for telemonitoring. The other huge gap that I just want you all to be aware of is Medicare. So most of the press that you see about Medicare and telehealth is very positive, not the case for home health. So Medicare has been flexible on from a regulatory perspective. So they said, you guys can do remote visits, go ahead, but they don't pay for them. And the not paying for them is actually really significant because of the payment model. The way it works is that we get paid on what's called an episodic basis for Medicare. So that means if you come out of the hospital, you've been hospitalized, you need care from us for 30 or maybe 60 days, that we get paid one payment for that whole episode, no matter how many visits it includes. So it is, in a sense, it's not really a fee-for-service model. What Medicare has said is that the visits that we provide through a remote mechanism don't count toward our payment model. and there's a threshold. So if we don't provide a certain number of visits, we don't get the full payment. We get, it's called the LUPA. It's basically a lousy, smaller payment. The L doesn't actually stand for lousy, but it might as well. So it's a much lower payment. So the problem is that it's called the LUPA threshold, and we're just not getting, have many cases that are not meeting the threshold that under normal circumstances would have. And this is going to persist through the foreseeable future. So our revenue is not going to pick up in the way that it might as it'll certainly pick up as hospitals are discharging people from surgeries. Our revenues will pick up. They are down about 30%. But there is going to be, our volumes will pick up, but it's not clear how our revenues are going to look, because we're going to have all of these low payments because of the blended model that we're using, which is public health appropriate, but it's going to be really tough on the agencies. So we continue to fight that battle at the federal level, and we're certainly working with our delegation, but it's something I want you to be aware of.
So do you know, I don't want to interrupt you, but if you could comment on whether or not you understand that the next CARES Act might include something that would affect this, or is this certainly only going to be through a CMS rule change?
It's not clear. So our national organization is fighting really hard for this. There are a lot of complexities. There's statutory complexities. There's just sort of CMS's general lack of enthusiasm for home health. It's incredibly frustrating. There's just a lot of kind of history to this. But we've got a lot of bipartisan support in Congress for this change. So I guess I would say I remain hopeful, but I'm not holding my breath either.
Thank you.
Yeah.
Do you have more testimony?
That's really the main things I wanted to say on this topic.
Okay.
I also just wanted to say something on behalf of the whole Provider Alliance group that I've been working with. So, which is just to let you all know, we are working on a group letter. Somebody may have referenced this before, but we are as a group going to be supporting continuing to have access to telephonic telehealth, especially given our lousy broadband coverage. It's really, we see it as an equity issue in part. There are lots of places in Vermont where we're not going to be able to provide care if the telephone isn't the way. So we actually think that's a change that we need to make permanently. And then we're also going to be recommending an extension of many of the emergency provisions that you put in place through H742, regardless of whether or not there's an emergency, we're under a state of emergency, since it's not totally clear whether we're going to go in and out of being in a state of emergency or stay in a state of emergency the whole time. But we know we're going to be moving in and out of peaks and valleys in this crisis for quite a while. So that's coming to you, and I just wanted to share that.
Thank you. So is that being sent directly to our committees? Good. That's helpful. It may put everything into one spot so we can understand it clearly after hearing all this testimony.
And credit to Helen who actually wrote it. So we're in the editing process now. We're getting really good at this Google Doc thing, so we'll get it finished up. Yeah.
All right. Thank you. Thank you for your testimony.
Thank you.
And for your work. We're very appreciative. And just as another comment, I have asked for data from both Dale relative to choices for care and data from DEVA relative to some transportation and other patient access issues to inform any decisions we make about the bill that actually it's a bill that the Senate Health and Welfare Committee has been looking at with Maria Royal. So as we go forward with that on Thursday, and I think that House Healthcare may be in on that conversation. I don't know what I think you are, whether or not we want to fold those two things, that together with the whole telehealth issue, or whether we want to keep it separate. So just a thought. Okay. Before I call on Representative Lippert, I did forget to acknowledge that today is Nurses Day, the day celebrating nurses in our country. And the rest of the week is International Nurses Week. So for the next week, we are celebrating our frontline nursing professionals. Representative Lippert.
Thank you, Senator Lyons. I think what I'd like to do is to first hear from other members who have questions who are in the queue. And I think, as you indicated, I think Representative Smith had agreed to hold his questions, and perhaps we'll hear from him, and then Representative Rogers.
Well, we have Representative Smith, and then Representative Chena, and then Representative Rogers.
Okay, thank you.
Right, so we've got a lineup.
Thank you very much. I guess I'm going to have to break this down a little bit. From 10 o'clock to 11 o'clock this morning is where these questions, I had these questions written at 11 o'clock. From then on, I've gotten some pretty good, an FYI group of things were answered in my mind. But the three questions that I have worked my way up to where Jessa Barnett started explaining things, and that started making sense to me. The first question is there something that we are trying to achieve or accomplish with this testimony? And the second question I've got is, what are the objectives of the witnesses' testimony? And the third question is, what is to be desired or expected from us as a result of this testimony? Maybe there's too many questions there and too many answers to be listened to, but
no, I think they're very good questions, Representative Brian. And I think that Representative Lippert and I, and maybe others who are planning the agenda, can respond to that. I think what you've heard is a strong support for having telehealth and telephone in place for various providers to improve patient access. And the concern is that the emergency is going to end. We don't know when, but when and if it does end, how do we maintain that access at least through a transition period, but that the COVID emergency is going to it's going to have its little waves coming along, waxing and waning. So we're going to see more of it and see less of it. And so rather than have rules and change, the question is, how do we allow for the telehealth, telephone to continue so that it's supported by everyone involved? I think that's a question, Bill, you want to?
Well, and I would add, Representative Smith, I would add, what have we learned in this process that might inform our policies going forward? And how do we balance what some would see as an expansion of billable services, which were much of which was not being utilized or wasn't being billed previously? What have we learned that can be implemented going even beyond the COVID situation, but balancing the fiscal pressures on both providers as well as the carriers, and of course DFR plays a key role there. So I see this as partly information gathering, but I think there are short-term COVID-related issues, such as clearing the gap or filling the gap between store and forward and the implementation date in January, but also particularly around the telephone.
Okay. Thanks, Bill. Thank you, Senator.
Thank you.
I guess I'd also say that I think when we entered into this, if you recall, we had actually started working on telehealth before the COVID emergency had emerged. And I think it's really, I think it's a credit to the work that the House and Senate Healthcare and Senate Health and Welfare Committees had done around the Rural Health Task Force last year, really looking at some of these issues. And that was one of the primary, or one of the highest recommendations, that we grapple with the issues of telehealth.
Sure, that's right.
I think it's fortunate we did that. We laid the groundwork before we got into the emergency, and then we built on that. And as we got into the emergency, even when we were in the House, we passed H742. It was conditioned on when in the event that a gubernatorial emergency shall be declared. It had not been declared when we were actually working on that legislation in the House. Of course, we modified that as it came, or it was modified as it came to the Senate. But I think what we couldn't anticipate then is coming out the other end. What does it mean to be leaving a declared state of health emergency, or how does the end of a declared state of health emergency actually, how do we integrate that with the fact that there may not be an official declared end or there may be an official declared end to an emergency, but the healthcare needs have not completely shifted. And I think we're going to need to continue to grapple with those issues. And I think some of the testimony today begins, it doesn't complete, but it begins to help us think about some of those issues as well.
Great.
Very,
Thanks.
very difficult to know when the virus is going to subside. I mean, that's really the unknown.
Yeah.
All right, Representative Smith, do you have any other questions that you'd like to ask? You feel
No,
that they answered, or-
I'm good with that, Senator. Thank you very much.
All right,
Thank you, Bill.
terrific. Representative Chena.
Thank you. My question, I think, goes mostly to Dr. Marvin, although anyone can answer it. Right now we've heard from people about how we're using telemedicine, how we quickly moved to using telemedicine, that we had laid the foundation for it and was starting to be used, and the healthcare system took this leap to using it. And there were a lot of easing of restrictions as part of that leap to make it possible. And we've heard about some of that today. Dr. Marvin, you mentioned how telemedicine could be used to treat patients across state lines, like people who move between Vermont and other places. And a barrier that I faced as a healthcare provider was licensing issues in different states. And a lot of states right now have emergency licenses. Like I applied for one in Maine, but they expire 90 days or 30 days, or so, depending on the state, they expire after the states of emergency are lifted. And so my question is sort of how do we continue to provide telemedicine across state lines when the emergency is over? Like, in other words, how do we, if we provide services to people now, how do we maintain that afterwards? And just if you or others could speak a little bit about what some of those barriers are, what some of the emergency solutions are, and what we would need to do both in Vermont and in other states to allow for an integrated system of telemedicine after.
Is that within your pay grade, Dr. Marvin?
This is revealing so many things I don't know. But, and Jessa may be able to help me out with this one, but right now, at least I find it just much better care to be able to provide care to our patients no matter where they are. And from what I understand as an FQHC, as long as there are patients, we can take care of them in other places. And we do. So Jessa, you might be able to give me some guidance on what that would look like moving forward.
Sure. Yeah, that's a great question. And it is something we are starting to think about because just as you referenced, a lot of the licensure flexibilities, both in Vermont and by other states, are linked to a declared state of emergency. So just so everybody is on the same page, even if it's through telemedicine, typically pre-COVID, you had to be licensed in the state where the patient was located. So if your patient even was in New Hampshire or Massachusetts, you had to be licensed in that state. Every state has gone different ways. Well, most states have gone different ways to add some flexibility to that during COVID. So some have completely waived licensure and said you can just be deemed licensed. Some have done expedited licensure. It's taken various flavors in various states, depending on their legislature and board of licensures. So we're very grateful that, for example, all of our surrounding states, New Hampshire, Mass, Maine, New York, have all done various iterations of those flexibilities, but those will likely go away when their states of emergency go away, as will Vermont's, allowing, say, DHMC's physicians or other providers to waive into Vermont to provide care to their patients located here. So that is something we are starting to talk about. We've and I would encourage you to hear from, say, Lauren Hibbert and David Herlihy on that. I think it's something we need to start thinking about quickly, especially if the governor happened to lift the state of emergency. We would kind of very quickly lose that flexibility. So what does it look like for the immediate term during COVID with or without the state of emergency? And then personally, this is actually kind of a pet interest of mine, is have we learned some lessons about how we could add some licensure flexibility for telehealth, for forever into the future? That's sort of a longer term question.
Thank you. That's helpful. Jen Carby, did you want to say anything? Or Catherine Fulton, you have your hand up. Go ahead.
Apologies on mute. A couple quick thoughts, just to echo everything Jess has said, absolutely, but also the opportunity to gather in some lessons learned from this crisis situation and be able to identify some real opportunities for improvement and what to keep and what to abandon as we start to emerge on the other side. And, starting to pull together later this week, we have a large group coming together with some initial planning discussion and exchange of ideas on what the other side may begin to look like. So again, garnering in what's worked here in Vermont and across the nation as best practices.
You know what, that's really very helpful. I know that in the Senate we have a task force trying to look at that, and it will all eventually flow into the Committee on Health and Welfare. So any information that you can provide to us on that, and I include both committees with that, whether it's for immediate legislative response or longer term responses, that would be very helpful. Thank you. Good question, Brian. Jennifer Carby, did you want to add anything?
Sure, I'll just add a little bit. I think one of the important parts of the question is, what is it that Vermont can do, and what requires other states taking similar action? So one of the big things that Vermont did a couple of years ago, effective just in January of this year, was to join the Interstate Medical Licensure Compact. I think telemedicine and telehealth had some role in incentivizing people to support that. But it makes it easier for physicians to be licensed in multiple states, with the idea, I think, being that then it made it easier to provide telemedicine services across state lines. And I think the Senate has taken up or has spent some time on the nurse licensure compact, which is similar. It's still on the Senate side. But for other types of providers, like Representative Gina, there would need to be something, I think, maybe similar or some sort of reciprocity agreements with other states to make that easier.
And that would be through OPR?
Well, OPR can make it easier for providers licensed in other states to practice in the mental health fields in Vermont, but we can't affect what other states would allow in the absence of either some sort of reciprocity agreement with those other states or an interstate compact.
Right. So we probably should be looking at what, if anything, is available on an interstate compact level.
Right. And OPR, I'm sure, has thoughts on all of that.
All that.
Medical practice for other types of providers too.
And just so folks know, we did pass the nurse interstate compact bill. For some reason, it got sent to Senate Finance Committee, and I've listed it as a priority to leave the Senate, because I know how important it is going forward. So next up on my list is I have Representative Rogers, Representative Lippert, and I don't know if Representative Smith has put his hand up again, but I have him queuing around. So I have McCormick after Rogers. Okay, Representative Rogers.
Thank you. I have a question for Dr. Marvin and a question for VPQHC. So for VPQHC, my question is, who are the members of the telehealth work group, and who was in the role of deciding who the members were for the work group.
Thank you, Representative Rogers. It's a very extensive list. I would be hard pressed to rattle them all off, but we'll happily send you the list of the members. And literally, we started the first meeting by asking the question, look around the room. And we actually planned the first meeting for our small little conference room down in our offices on Main Street. And 30 folks showed up, 30 people arrived. And so we were standing room only. Our first question was, who's missing, who needs to be included here? So the list now is, I believe, over 40, 45 members, and we'll provide you with the entire list.
So if you don't mind, please send that to Nellie and Demis, and then we'll have it available for both committees.
Thanks. So the outreach
Absolutely.
as far as, you know, what would have been required for someone to be aware that this first meeting was happening and show up? Like, was the outreach through the VPQHC networks, or how was the outreach to recruit potential members?
I would say through our networks, our key stakeholders, our usual suspects and partners in work. You know, we asked for some recommendations from the Hospital Association, insurer partners, certainly Jill Olson, Jessa Barnard are part of Helen. I'm looking at the screens, looking at who's present here this morning, and many others. We've also included independent practitioners, designated agencies, all the insurers. I'm going to look at Hillary and say, who am I forgetting as in terms of maybe categories?
I also do not have the list memorized. So I think it would probably, but it did start, the outreach started with our core stakeholders and those that are paying into the Build Back funding and expanded from there.
Thanks.
Okay.
And Representative Rogers, it's not closed. It is an open forum, and we encourage everyone to join us. Representative Houghton has presented and shared in the meetings as well. So feel free to join at any time.
Thank you. And then for Dr. Marvin, I was just wondering if you could speak a little more about the burnout side of things, and what are you seeing and hearing and feeling from the provider community as far as the impact of COVID on that, and then the impact of COVID as one question, and the impact of transitioning to more telehealth as the other side.
So that's a big question. So I think there was a certain amount of burnout before all this, unfortunately, especially in primary care. So we're just kind of doubling up on that. The transition to telemedicine, I think, I hate to say it might be a little bit generational. So some of our providers are having a harder time than others, and they actually probably have a generational patient base as well. So that just adds to the frustration if their patients aren't able to connect or aren't happy with the care because it's not what they're used to. I mean, I think that in general, we have been extremely lucky. You know, I have colleagues and peers from medical school and residency who work in Manhattan and Seattle, and I'm in close contact with all of them. And I'm on several humongous Facebook groups for physician-only providers in the US. And just to hear their stories and what they're managing and how they're trying to balance family life and taking care of everything is just incredible. So with our low census here in Vermont, we're pretty lucky. So from a COVID perspective alone, I'm less worried than I was at the beginning of all this. We're not seeing the surge, at least not yet, that we were planning for if needed.
Thanks.
Okay. Thank you. All right. Senator McCormick.
Yeah, I have a question for Jill Olson. Jill, and I apologize if maybe I just wasn't listening carefully enough. I want to make sure I've got this clear. You had discussed problems getting payment I want to make sure, are the problems with both Medicare and Medicaid or with just one of them? And secondly, was that just for telephone care or was it for telemedicine as well?
The problem is with Medicare only, and it's for any kind of telehealth. We're not being paid for that work at all, and because of the way our payment model works, it's an especially large hit.
The problem with the way our payment model works? Is that something we could correct?
No, it is a federal problem.
So at this point, we're just stuck.
Yep. I mean, we're certainly doing federal advocacy, and we also, of course, have potentially flexibility for other types of services through the all-payer model, but we haven't gone down that path at this point. So
okay,
it's too early for that. It's too early. We're going to keep the federal advocacy going at this point.
Thanks for the clarification. I'm
All right. Thank you. Representative Lippert.
Thank you. I want to just emphasize one point and raise a separate question. The point I want to emphasize is that until we resolve our broadband issues across the state, to say we have telehealth available through video and audio is actually not realistic. And so therefore, because we do have audio access for the most part across the state, we must, I think, reevaluate the longer term access to audio healthcare with all the attendant questions of medically necessary care, et cetera, and quality of care. But I just want to underscore that. The other point I would make is that as we begin to look beyond COVID emergency situations, we had begun a great deal of work in the House Healthcare Committee around the healthcare workforce generally in Vermont. And I think we need to prioritize that work as we begin to move out of COVID emergency legislation. While, so I just full stop there. We have a healthcare workforce issue in Vermont that is significant. We need to prioritize that as we move forward between both of our committees and on behalf of our colleagues and our communities. In addition to which, we need to begin to understand what has been the impact on our healthcare workforce of the COVID emergency. What has that layering on the impact of the COVID emergency on top of an already terribly stressed healthcare workforce? What's the further impact of the COVID emergency? But I just think we need to not move away from the work that we did in terms of training and support for strengthening healthcare workforce issues in Vermont.
So that's an excellent point to be made, and particularly while we're looking at what's going on with the state college system to really reinforce the programs that support new workforce.
We have critical training programs that actually
Absolutely.
support not only the healthcare workforce but the workforce generally in Vermont. But I agree with the healthcare.
Yeah. All right. Thank you for that comment. Senator McCormick, your hand is still up. Do you have another question? No. Okay. Representative Smith, your hand was up, or was that just a residual?
That was from the first time, and I just lowered it a moment ago.
All right, good, thank you. Any other questions from folks? We have quite a team here with us today, and I actually, I encourage any of you who are here today testifying to join us as we talk about telehealth and telemedicine. As you look at our agenda, and I've mentioned it already for Thursday for VPQHC and others, and if you're interested in providing further information as we move forward on that section, please let me and let Nellie know, and we will Zoom you in, because I think it's important for us to say moving forward on this. Anything else?
One
Oh,
last comment.
go ahead.
One last comment, Senator Lyons, if I may, that I think today is a good example, again, of trying to efficiently use the resources of the hardworking folks out in the field who are helping to implement policies and support healthcare workers and healthcare broadly by having one opportunity to testify before both of our committees. And I think so.
And now we're going to give them two opportunities to testify for both of our committees. That's great. Thank you all. And so in tradition of Senate Health and Welfare, and it's now been caught on to by House Healthcare, we finish early. I want to thank you all again for today, and Cinco de Mayo. Have a good day. Take care. We're ready to leave. We're ready to leave
you.
the meeting, Nellie.
Ending live stream now.